Perfect. So in the interest of time, we are going to get started. So welcome everyone, and thank you for joining us today for our question and expert session. My name is Bakun Adebembo, and I'm the Manager of Operations with the Canadian Breast Cancer Network. So before we get started, I'd like to cover a couple of housekeeping items. So this session is being recorded, and it'll be available on our website for anyone who may have missed it or wants to rewatch it. The link for the video will be shared via email once it's been uploaded to our website. I would like to extend our sincere appreciation to our sponsors for this event. So our gold sponsor, Viatris, our silver sponsors, Novartis and Amgen, and our bronze sponsors, Gilead, Merck, and Seagen. Our question and expert sessions are strictly dedicated to answering your questions, so there will be no presentation from our speaker, and he'll be answering live questions from participants, along with ones that have been submitted in advance. So please use the Q&A button at the bottom or side of your screen to submit your question, and we'll aim to take as many as possible. I'd now like to welcome our host for this session, Kathy Amandaleo, Chair of the Board of Canadian Breast Cancer Network. Kathy?
Thank you, Bakun. Welcome again, everyone. Thank you for joining us. I'm pleased to welcome Dr. Mark Basik, who is joining us to answer all your questions about clinical trials for breast cancer. A little bit about Dr. Basik. Dr. Mark Basik is the Herbert Black Professor of Surgical Oncology at McGill University and the Director of the Cancer Genomics and Translational Research Laboratory at the Lady Davis Institute and a surgical oncologist at the Jewish General Hospital. Dr. Basik's medical practice and research are focused on treating breast cancer, especially hard-to-treat breast cancer subtypes, such as triple-negative breast cancer, and developing new blood tests to monitor patients with breast cancer. Dr. Basik, thank you for joining us this afternoon. It's wonderful to have you with us today, and we look forward for a great afternoon session.
Thank you, Kathy. I'm happy to be here, and hopefully I can answer some of the questions.
Okay, so while we are waiting for participants to start submitting their questions, I will begin with the pre-submitted questions. And before that, can you tell us a little bit of about clinical trials and how you are involved with clinical trials? So maybe just a little bit an overview.
Mm-hmm. So I'm a surgical oncologist. I'm a surgeon, a breast surgeon fundamentally, but I've been involved in clinical research for many years. And I practice at a center, at the Siegel Cancer Center, the Jewish General Hospital, where there's access to a lot of clinical trials. I deal mostly as a breast surgeon with early breast cancer. That is the kind of breast cancer that gets to be operated by me or by my colleagues. And so the clinical trials that I'm usually involved in deal with early breast cancer, such as different modalities of treatment related to either surgery, radiation, or chemotherapy, or other drugs that are given around the time in women that have early breast cancer. So I've been the principal investigator of several clinical trials in the past decade or two. And I'm working also a lot. I have a lab, so I'm also working on bringing some of the scientific discoveries we make, or some of the laboratory discoveries, to the clinic. And so that's called translational research. And so some of the clinical trials, and those are the kinds that really are dear to my heart, are the ones that we are trying to use these kind of discoveries or use science to either improve the treatment, give less treatment if possible, or in some way predict what we should be doing in terms of therapy using different kinds of tests.
Great. So just a little background. Now, when patients hear about clinical trials, often they'll either be asked to some patient will be asked to participate in clinical trials, and some patient will be asked to participate in studies. And I think that some patients get confused with both. Can you give us a little bit of an overview of both? Are they the same? Is there similarities? And what are the differences?
Well, clinical trial is, I guess, a bit more official, perhaps, than even more rigorous than a study. clinical trial involves usually, it's an experiment that is performed with the patient's consent, either testing new drugs, testing new tests, or I mean, it could also be other more, I guess, less testing kind of procedures. But usually that involves new treatments or new tests. And so there's issues sometimes of safety, which is why clinical trials have to be done in a very rigorous kind of way. They've got to be done in a center that has the capacity to deal with something new, or new side effects sometimes can happen with new drugs, or and really support the patients that are doing this. Studies are, in a sense, the broader term. Clinical trials are studies as well, but studies could be, for instance, a questionnaire. It could be more of a study on well-being or on certain side effects from certain treatments. That could be perhaps a study, or that could be, it's a bit of a broader term. Clinical trials more of a rigorous, I guess, form of experimental testing of something.
Okay,
I
great.
guess it's a
Thank
very
you.
broad, sort of generic kind of definition.
Yeah. Often you get asked by patients often wonder what is the difference. So it's good for us to get a little bit of an overview. I'm going to now start with some of the questions that were submitted previously. And one of them is, what are some of the most promising breast cancer trials being done right now, currently?
So that's a very big question. There are many clinical trials that are open right now, and they're about to be open or just about closed. Clinical trials in breast cancer cover the gamut from new treatments to new tests. There are many new exciting treatments that are being tested right now in early breast cancer. These kinds of drugs, for instance, what are called antibody drug conjugates, meaning you have an antibody that finds the cancer cell, and this antibody is linked to another drug. The cancer cell swallows up the antibody, but with the antibody, it swallows the other drug, and it's like a Trojan horse, and it dies. So there's also a whole new series of drugs that are being tested right now in clinical trials in breast cancer, and they seem to be very effective. There's a lot of clinical trials that are looking at what we call de-escalation, meaning not to give treatment in some women. If you have a certain biomarker, certain test that can say, well, you don't need to give that kind of treatment. And so those are clinical trials also that are ongoing. They're trying to test this kind of approach. Let's give less if we know who doesn't need that much the extra treatment. So there are new ways. So, for instance, giving radiation therapy in only a subset of patients, and they're testing things like that, or other tests. One of the most exciting tests that are being tested is something called circulating tumor DNA, which is a really exciting way of finding out if there's still any cancer cells hiding in the body with a blood test. And so there's a bunch of clinical trials that are now coming around. They're being designed now to try to either give more therapy if you know that there's some cancer cells lurking in the body and you can't find them, or not to give therapy if it looks like it's cleared. For instance, the surgery is cleared the breast cancer, and so you don't need perhaps any further chemotherapy or others. So there's a whole slew of trials that are being designed looking at that. And then there's all kinds of different kinds of interventions, but those are perhaps the most popular ones right now, the ones that are really open and that are sort of exciting. I have a question here on the, I don't know if I should just look at this, define early breast cancer. Breast cancer, what I mean by early breast cancer is breast cancer hasn't spread outside the breast and the lymph nodes, meaning like to the bones or to the liver and so on. That's what I call early breast cancer, or what we call stage 1, 2, or 3 breast cancer.
Right. Great. And what about the feeling of always making sure there are trials? Should we be, as a population, should we be concerned that trials and research is a little bit slowing down, perhaps? Is there still the momentum of us not having to worry about stuff like that?
No, I think there are always new discoveries being made, and they have to be tested ultimately in a clinical trial for them to change practice, right? So there's, there's quite a few clinical trials around, there are quite a few, There are new diagnostic tests that are being developed, as I just mentioned. There are new drugs that are being developed, other kinds of treatments that are being tested as well. So no, I think there's a lot. There are a lot of clinical trials that are around. Whether they're available in your particular place is another question. And so a lot of, obviously, if you go to a bigger cancer center, I guess the bigger the cancer center, the more likely you can have more clinical trials. But they're usually there, and we strongly encourage them, because it's been shown that people who go on clinical trials, their outcomes can be a little bit better. And that might be for two reasons. One, because they might be getting a better treatment. We don't know, obviously, at the beginning of the clinical trial, but if half the patients get that new treatment and then it turns out to be a better treatment, well, you know, the clinical trial will have resulted in those patients doing better. Or just the fact that that patients who go on clinical trials are being monitored very, very, very carefully. There's a very close monitoring to make sure there's no untoward side effects or unexpected things that happen. And that in itself, I think, helps also in the outcome of patients that are on clinical trials.
Great. The other question I have here is whether the clinical trials are free. Like, I guess they're wondering, is there a charge for patients?
No, there is no charge. Clinical trials often involve, as I just said, coming in perhaps more often to the hospital. So that could be what we call maybe a bit of financial toxicity. In other words, that could be a cost that would be unexpected. Clinical trials try to compensate for those kinds of things, like parking, whatever, or transport, but maybe they don't do a perfect job there. So there could be, in that sense, some extra cost to the clinical trial. But in general, no, clinical trials are free for patients. Yeah, that's
Okay.
not a...
Good to know. So I have another question here. When the trial ends, are participants told if they got the standard of care or the treatment being studied? I guess they want to know what they fall under, where they fall.
Yeah, in general, yes. The question is the timing. We sometimes don't know how soon that can happen. If the follow-up is for a very long time, sometimes it depends on a clinical trial. Some clinical trials keep both the investigator and the patient blinded to which treatment arm was given, so as not to bias the results in any way. And so that could take sometimes years to find out where which arm you're on. But in general, yes, you would find out, and your treating doctor should find out and can tell you and should tell you which arm you're on.
Great. So I'm going to hand it over to Bakun because we have incoming on-site questions. So go ahead.
Thanks, Kathy. So we're talking a lot about clinical trials and patients being on clinical trials. So I guess just to back up a little bit, where do patients actually learn about clinical trials? Where do they find information so that they can join these clinical trials that are open?
Yeah, so that's an excellent question. From their treating physician, from their oncologist, first of all. The oncologist should be aware of the clinical trials that should be open at their center, at his or her center. So that's the first source of information. But there are websites as well that are available. I know in Quebec, there's this GEOQ website, GEOQ, where there's a list of clinical trials. I even checked it earlier today. It's not quite up to date, but it's not bad in the sense it has some of the clinicals already closed, but it has most of the ones that are open are there. I know Ontario has a clinical trials site as well. If you just Google it, clinical trials in Ontario, you'll find, although it seems that it's under construction or being redesigned right now, so it's not quite available. But you can do it that way. There's an actual clinical trials NCI site called clinicaltrials.gov. And that gives you all the clinical trials, and you're going to be swamped with hundreds of clinical trials. So, and you don't know whether they'll be open at your site or available in Canada or not. But that's the ultimate site where you can find out what's available in terms of clinical trials.
Perfect. So I have a question. So how long after a clinical trial, I guess, ends until something becomes like the practice or the norm? So when does something go from being tested, the study finishes, to it now becoming the standard of care?
Yeah, so that's also a good question. Depends on what kind of follow-up is necessary. Sometimes you need 5 years of follow-up for survival, sometimes 10, sometimes 2. So it depends on the context. Some cancers are more aggressive, so you need less follow-up. You can tell quickly. Others are more indolent, and you need longer follow-up to find out whether the intervention or the test has made any change. So that's what happens. You wait for that result to be mature. So then they're presented usually at conferences, international conferences, and they're published. And then depending on the result, there's a consensus then of oncologists that usually reads these and discusses these results and decides that these are practice changing or not. And if it's in the case of a new drug, for instance, then the next step would be for the company that makes the drug to go to like Health Canada, and then eventually to the provincial agencies to decide whether that drug is available or not. So it's a long process, but once a clinical trial is mature, the results are presented, must be presented, and must be published. And then the community of oncologists, depending on the results, decides whether these are practice changing, and if they are, then they proceed to make them available.
Perfect. Kathy, back to you.
Yeah, and keeping within that same discussion, what can you name? What can you tell us? Which practices are now done that have come out of a clinical trial, like I guess some drugs, some chemotherapy, combination of either. What is our standard of care? I mean, that's a very big term that we now apply on patients that has come out of a good clinical trial.
I'd say many, but not all, but most current therapies for breast cancer, any cancer, have come out of clinical trials. The most recent one, which resulted in a serious practice changing, was the addition of an immune checkpoint blockade inhibitor, or what we call immunotherapy, to the chemotherapy regimen of patients with early triple negative breast cancer. And so that's something that was a clinical trial we participated in, and it showed that giving this drug that, in a sense, unleashes the immune system to chemotherapy helps the effectiveness of chemotherapy, so that the tumors respond better. And this is in patients in triple negative breast cancer before surgery. So at the time of surgery, when they come surgery, is actually more of a chance there's nothing left of the tumor. And so that's a recent clinical trial, let's say, it was published about a year ago, and that led to a clearly change in practice.
Great. I have another submitted question. How much time does it generally take from one's application or request to enroll in a clinical trial to actually start treatment?
So that depends. Essentially, there are criteria. There's eligibility criteria and exclusion criteria for every clinical trial. They're very rigorous about that. And depending what they are, the research nurse or assistant who's monitoring the clinic or taking charge of the clinical trial in your center has got to basically go through all these criteria. Some of them might involve some blood tests, electrocardiogram, x-rays, and how soon they've been done, whether they have been done not too long time ago. And so all of this has got to be checked. So sometimes it can take a week, sometimes it can take a couple of weeks, depending on what is required for each clinical trial.
And another question we have is, how do we access information about what clinical trials are available if we aren't currently being followed in a cancer center? So I guess people that are not in a cancer center and, rural communities or somewhere else outside.
Well, you just provided one of the links, the CBCN link, in fact. But as I said, you can go on all those websites that I mentioned earlier, whether it be the GEOC website here in Quebec, the Ontario one, the CBCN one, and then there's usually a contact person, and contact the person or write an email or phone to the person who's in charge of a particular center and see if they're available. That's how you can get in touch. Even if you go on clinicaltrials.gov, the master website, there always is a phone number people to get in touch with.
And still discussing access, how difficult is it for someone to understand that these clinical trials are available when you're outside the big centers in our country?
It's not easy because you might, if you're oncologist, if your treating physician doesn't know, then it's harder to know about them. And it's outreaches like what you're doing here today contribute to spreading the news that there are clinical trials, and then if you're oncologist, you should ask your treating physician above all, are there clinical trials for my condition, or can you check that if there are? And then hopefully she or he will do so and get in touch with you, or if not, provide places, websites where that can be done. And I'm sure that if they contact the CVCN, I suspect that you can help them as well.
And if the clinical trials are not available in those regions, how would they have access to travel to the centers?
Then becomes a problem, obviously, because a lot of, especially the ones with new drugs, you need to be close to the center that's giving you drugs, because if there's any unexpected side effects, they need to be able to take care of you and monitor. So that becomes problematic. And I've known people that have actually moved temporarily to a place where a clinical trial was available to get the drug or to get the treatment, whatever, and so that they could actually have access and receive, at least have a chance of receiving the new therapy. You have to always remember that most clinical trials, or many clinical trials, actually there's sometimes a randomization where half the patients don't get the new therapy, half the patients do. So it's not guaranteed that going to clinical trial you actually get the new therapy. But I've known patients that have actually moved to places so they could actually get onto the clinical trial. Obviously, it's very expensive and very difficult.
And can you explain a little bit more about the being on the trial with the drugs that are being tried and not falling into that category? Some would say, oh my goodness, if I don't fall into the category with the drug that's being studied, what happens to me? Can you clarify that a little bit?
In those clinical trials where there's a randomization, and those are what we call phase 2 or phase 3 clinical trials, a part of the people get the new treatment or the new test, and the others don't. The ones that don't are supposed to, and basically do, get standard therapy. In other words, you get the same therapy as anybody would get not in a clinical trial. So you don't get anything less. In fact, you get more because you likely be monitored very closely, as I said earlier. So actually your care will be a little bit even better. But you will not be getting then the new treatment if you're not randomized, if you're not selected or randomized to that arm. So it's a roll of the dice, if you will, in these randomized studies. But you have usually at least a 50% chance of getting a new therapy. And if not, well, then being followed very closely. And sometimes what happens is, especially in more advanced disease, what happens is that if it becomes clear during the clinical trial that the new therapy really is working very, really well, what then is allowed is that for the other arm, for the control arm, to receive, to cross, what we call crossover, and receive that new therapy. If we really see that, there's a real advantage. And during the clinical trial, these results are often monitored. There are committees, independent committees, that look at the results while it's going to make sure that nothing terrible is happening, but they also can discover that something beautiful is happening. And in that situation, then it is possible for then for the individuals who are on the control arm to then cross over and get the new therapy if it's working really well.
That's great. That's great. I'm going to hand it over to Bakun with some live questions.
Thanks, Kathy. So I'm going to combine two questions here because they're both on recurrence. So it's just generally, are there any clinical trials to detect recurrence? And then specifically, are there clinical trials for women with TNBC who have achieved PCR but want to take something to prevent recurrence? So just basically clinical trials and studying like recurrence.
So to prevent recurrence, I mean, first of all, to diagnose recurrence early, I guess, is what you'd like to do. And so what I mentioned earlier, these circulating tumor DNA, this idea of this blood test of finding the DNA of the tumor in your blood, is being tested now in some clinical trials, so to be able to predict the development of recurrence far in advance, even before CT scans or before any symptoms. Those trials are starting now. They're beginning to start, and they're beginning to pop up now, so to be able to develop. There are also different kinds of scans that are being developed as well, imaging, that are also being tested in clinical trials, but usually it's some sort of test like a blood test. And so, yes, those are coming to the fore. There's not that many yet open, but it won't take long. In the next few months, I think we're going to see a plethora of these kinds of tests, these kind of clinical trials looking at and essentially following patients that are okay and seeing if the test develops anything, and then depending what the test shows, doing something or not about it, perhaps giving a therapy. There was one that was presented with using circulating tumor DNA about a year ago, and there are more coming up. So that's the first part of your of the question. The second question, for triple negative breast cancer, how, if I have a complete response, how do I know that I have a recurrence? Yeah, in fact, your prognosis is really, really good. And right now, the question is whether you need to continue any further therapy after that. For instance, women are on this immune therapy, and they have to continue it for 6 months after. And so the question, there is a clinical trial that's about to start, if it hasn't already started. I know it's available in the States, and I think it's coming here as well, where they're going to be randomized to stopping that therapy or not. But that is because the prognosis is so good. But it's true that there's a very small percentage, less than 10% probably, of these patients that will have recurrence. And at this point, there's no standard therapy of standard way of knowing who they are, except for probably, I would say, the best is circulating tumor DNA. But those trials are still being planned and they're being designed. And so, yeah, that's probably the best way of knowing whether you have recurrence or not. But again, those clinical trials are still not there. And so it's not clear how useful those tests are, but they look very promising. That's what I can tell you. And they need to be tested in clinical trials.
For sure. And then speaking of tests, someone's asking, can you help them understand the Oncotype DX and, testing for BRCA1 and 2? Like, when is it beneficial? When should someone do this?
Okay, so that's the Oncotype DX is a genomic test. It's a test of several genes that is done in particular types of breast cancer, those that are hormone receptor positive, that express estrogen receptors. And in certain contexts, they help to decide whether you need chemotherapy or not, fundamentally. So that's actually the standard of care. As long as we're not talking about clinical trials anymore, people are doing them in women that have these kinds of cancers. However, there are some clinical trials that are still using these tests to, for instance, give less radiation. There's a clinical trial on right now in Canada, and it should be available in most Canadian centers, in which women that have the breast cancer has gone to their lymph nodes, that usually have radiation not only to the breast but also to the lymph nodes. Well, we're doing the Oncotype DX on those, and if the Oncotype DX is good, well, then they're randomized not to get the radiation or to get the radiation, or to get less radiation, because the Oncotype looks good. So that's a clinical trial that's actually ongoing right now. And I encourage you, those women who are in that situation, to ask about it, because it's a really interesting clinical trial that will allow us to give less therapy if it's not needed. The other part of the question, I forgot. It was about the Oncotype, or the BRCA1. Yeah, so that's genetic testing. That's also blood tests to determine whether you have a gene in you that was responsible to some extent of the kind of breast cancer that you have. These genes are passed down from generation to generation in families. And so if there's a strong family history, those tests are done. There's certain criteria for doing those tests, and it depends on each center. Here at the Jewish General, we're beginning to do much more on almost every woman that has a breast cancer, especially the more aggressive kinds of breast cancers. And that does determine, obviously, therapy. It determines what kind of surgery you may have, and also what kind of therapy you'll have, what kind of drug you may need after the surgery. So that's an important test to be done. And many women should have that test done.
Perfect. And another question related to tests. So this is asking if there's any clinical trials for lipid biopsies, such as Guardant X or Signatera.
Yeah, so those are the circulating tumor DNA kind of tests that I was talking about. Those are two companies that are offering them, Guardant and Signatera. And there are some clinical trials that are coming soon that will be using those tests. Yeah.
Back to you, Kathy.
Yeah. So in that same sort of discussion, when a person is given the option of doing less instead of doing the current standard, like you said, less therapy, less radiation. Do you find that patients often become a little, uncertain about getting less?
Yeah, that is, it's very, very much a personal thing, right? I mean, the reason often those trials are thought of by the doctors is because the patients asked for less. I actually I'm spearheading a move to do less surgery in those women that have a complete response, like you talked earlier, the PCR in women with that have chemotherapy prior to surgery. Why? Because women were asking me, why do I need to have surgery if there's no more tumor left? Why do I need radiation? We have a clinical trial that's starting now to avoid radiation, those women that have had a complete response. Why? Because that came from the women themselves, that they asked, why do I need radiation? I said, that's a good question. We should test that. And so we are testing that. And then the other hand, there's the other, then you're right, then there's the other individuals, other women who are very much concerned about not getting full therapy, and they are free to decline participation in the clinical trials and wait for the results. That's also been the case. For instance, there's a clinical trial in which we give less radiation to the lymph nodes when there's nothing left in the lymph nodes, and that was open. And some women said, no, I want to get the radiation, I want to get the full therapy, I don't want to take that risk, and that's perfectly okay. Until we have the results of that trial, we really don't know if they're right or wrong, and we'll know when the results are out.
Okay, great. So I'm gonna ask you some submitted questions. Do patients have any power to influence how quickly they may be accepted for participation? The person is asking because she's wondering how about situations where a patient might feel that their disease may progress too quickly to enable them to benefit from participating in a trial.
Yeah, that's a real issue, a real problem, especially in women with metastatic breast cancer. Because certain criteria need to be met, and if they're not, then boom, you're no longer eligible, and time could be of the essence in some cases. So I would just say that that the research team with the oncologist and with the patient have got to work in a timely fashion to make it happen. Sometimes for all kinds of reasons, the pathology is not ready, or some exam hasn't been done in the last month and has to be redone, and it's not that easy to get a scan in one day, and so on. So then it leads to delays, and sometimes, unfortunately, it leads to patients then becoming ineligible for clinical trials. I don't know what to say. We have to try to do our best to accelerate things and to make things happen. But you're right, there's some clinical trials for which there are certain windows, and if you're out of that window, well, then you're no longer eligible, and that's unfortunate. And the reason for that is, I guess, for this to make it scientifically rigorous so that, they can understand the results of the trial. But it's, sometimes it's too rigorous, but that's the way it's designed. And yeah, you have to do your best to hopefully make it happen and make it happen in time.
Yeah. The other question is, do you know if clinical trials that address lobular breast cancer, specifically, are there clinical trials that look at the difference in treating lobular cancer by a lumpectomy versus a mastectomy?
So there are clinical trials that are running that are specifically designed for lobular cancers. There aren't any open here now or in Quebec, I think, that I'm aware of, but I know there are some. If you go on clinicaltrials.gov, you will find them. There are not that many, but there are several. I'm not aware of any clinical trial looking at lumpectomy versus mastectomy in lobular cancer. I know that the old studies where they looked at that showed that it was safe to do a lumpectomy in lobular cancer. But in general, you're right, there's more of a risk of there being other deposits of the cancer inside the rest of the breast. And so we're usually very careful and order MRIs of the breast in these women that have lobular cancers. But lumpectomies are feasible. So I don't think I'm not sure that there will be such a clinical trial. There are clinical trials are ongoing to try to see whether MRIs change the extent of surgery. And it's true, they do change the extent of surgery, but whether this has actually an impact on survival, in other words, in the breast cancer coming back in the future, is not clear. and that has not yet been demonstrated.
I have a quick question. What is the age group of lobular cancer mostly?
The
Is that
usual
any
age group, yeah, in the 50s, 60s, 70s, yeah.
not premenopausal, right?
There could be premenopausal,
Yeah.
but less so, yeah.
Yeah, yeah.
There could be.
Okay, yeah, just curious. I'm gonna send it over to Bakun for live questions.
Sure. So this is another one on a specific type of breast cancer. So are there any clinical trials for hormone positive and HER2 low breast cancer, specifically looking at endocrine therapy?
The as one said, I guess hormone positive, HER2 low, right? That particular type of cancer, or both, or either, because you can divide them. It's one.
They said, and I'm not sure if they're looking separately, but we're
Okay,
going
well, I assume it's
looking at
together.
one, yeah, together.
Yeah, so that's an interesting question because HER2 is one of the key proteins, right? Growth factors in breast cancer, and there's a wonderful target drug, Herceptin, that's developed 20 years ago. That's very, very effective, also thanks to a clinical trial. But it was given to those patients that have the tumors that have lots of expression of HER2. But there are now these, what I mentioned earlier, these antibody drug conjugates, these new drugs that have shown to be effective, even when you have an antibody against HER2 with a drug attached to it, that are effective even in those breast cancer that express low levels of HER2, like in this particular case. And so there are studies showing that some of these antibody drug conjugates, some of these drugs, are actually very effective in particularly that kind of breast cancer. So they need to have a bit of HER2 expression so that the antibody could find a cancer cell, and once it does, it's gobbled up by the cancer cell, which then dies because of the poison that's attached to the antibody. So there are drugs that are effective. They're being tested also in clinical trials too, also in that group of patients that are being mentioned. But in metastatic breast cancer, those drugs already have shown in clinical trials that they're effective and they're being used. So that is effective. The second part of the question was I thought there were two parts.
Well, I was just asking like specific endocrine therapy, but it's just all one.
Yeah, that's not endocrine therapy. That's an antibody drug conjugate.
Yeah.
There's no specific endocrine therapy, to my knowledge, that is targeting those patients at this point in time. The usual endocrine therapy that we give for all hormone receptor positive breast cancers is effective in these kinds of tumors as well.
Kathy, back to you.
Sure. Are there clinical trials about ovarectomies versus Gosserlin injections with stage 4?
Yeah, that's a good question too. I'm not aware of any trials. I didn't look. One can look it up, I guess, on clinical trials. I don't think so. Often in clinical trials, those two are interchangeable. You can, when in terms of ovarian suppression, sometimes the clinical trials allows the woman to have or remove the ovaries instead of getting the injections. But most of the clinical trials have tested Gosserlin and ways of cutting, completely suppressing ovarian function through these medicines. So I'm not aware of such trials, but in general, in the past, those two are essentially very similar in terms of the effects that they've had.
And for hormonal positive breast cancers, even in early stage, are there any trials about ovarectomies, prophylactic? Like, I mean, do certain criterias meet that? Wanting to understand if that would increase the survival rate for some women?
Not that I'm aware, not specifically the ovarectomies. So now let's separate prophylactic, which is something for breast cancer, for BRCA1, BRCA2 mutation carriers, who have a hereditary disease of potentially ovarian cancer. That is another story. And there we do ovarectomies, that's a standard of care right now. But in terms of even in premenopausal women with early breast cancer, again, I'm not aware of such trials. They may be there, but I don't think so.
Okay. The other question is, can you get into a trial when you are on your first line, or if you have progression from first line instead of using standard of care treatments?
That depends. Depends on the kind of cancer and the context. It's a complicated question. If it's a kind of cancer we know doesn't respond all that well to first line, well, yes, the earlier you find a clinical trial, the better. But if it's a kind of cancer that you know that there's second, third, and fourth line that you've shown to be effective, then unless the agent that is being tested, the drug is like incredibly exciting, it has these amazing results, then it's probably better to go through these lines of therapy before you get to something that's experimental, whose efficacy is unknown and whose side effects are unknown as well. So I would not recommend it. In the first line, usually there's a standard of care. No doubt, triple negative breast cancers are the most aggressive kinds of breast cancers, and the first line is there, but one goes very quickly to clinical trials there because the second and third line are not usually very effective. So it depends on the kind of cancer the kind of breast cancer you'd have.
And how easy is it to get? I mean, often we understand that it's difficult to cross over from, first line to second line because of certain criteria, budgets, etc.
Well, first line, second line, that's standard of care that you shouldn't have any problems going through. And if the clinical trial is available, well, then, by the eligibility, you meet the eligibility, then you can go into the clinical trial. That shouldn't really be a problem going from, but you're right. But some clinical trials want you to have gone through 2 lines of therapy before they test it, for instance. Well, and they're limiting in a sense the patients that go on to a clinical trial for the sake of scientific rigor, or they have some reasons to believe that their drug works better after the tumor has gone through various therapies. And if it works, if the clinical trial is possible, then we get all excited. Oh, they've got a new drug, but we have to give it after those 2 other drugs. And the question is, well, can we give it earlier? So sometimes we have to repeat the clinical trial earlier to see after longer, after 2 lines, after first line, does it work, or does it work as first line? So that's something that happens in the progression of things. And if we find something clearly, in general, when a drug works well in a metastatic setting, we want to try it earlier, and that's what's happening with a lot of these new drugs I was talking about earlier. They worked really well in the metastatic setting, and now we're testing them in early breast cancer, even before surgery.
Thank you. Bakun.
Yeah. So we spoke a bit earlier about radiation. You spoke about not wanting to how patients can avoid radiation, but this is for someone that has been treated with radiation and surgery, but without chemotherapy. Is there any do you have an estimated percentage of what the recurrence rate, how it helps patients? So you get surgery and radiation, but you don't get chemotherapy.
It depends on the characteristics of the tumor. It depends on what kind of tumor it is, whether it's hormone receptor positive or triple negative or HER2 positive. And then if it's hormone receptor positive, depends on tests like the Oncotype. They tell us precisely how much of a gain chemotherapy can give you, depending on the score of the Oncotype, or other tests as well. Oncotype is the most used in Canada. So it's a question I can't really answer. It depends on the specifics of the tumor.
And then you spoke a little bit about diagnostic testing. So I don't know if this be in the realm of that, but if someone's ultrasound mentioned multiple surgical clips were seen in the center of the breast, they're wondering what does this mean? Why are surgical clips used, and is there any risk from the clips?
No, there aren't. Clips are used at the time of surgery to clamp blood vessels, and so they're just there. They're in there. They do nothing. We also put in clips if women have lumpectomy. We put in clips to also show for the radiation therapist where the tumor was, and so they can focus in sometimes an extra, what they call a boost, to what they call the tumor bed, which is delineated by these clips that we put in at the time of surgery. So that's a completely normal mammogram result.
Kathy?
Okay. next question here, pre-submitted. Are there any clinical trials that have been done or currently being done on detecting breast cancer by mammogram versus MRI versus ultrasound? I guess they want to know.
Yeah, there are some there, and I'm not aware of any here now, but I know there have been some that have been reported, and there are studies that are ongoing. I think there was a study from Sweden that was presented last year, the year before, on the MRI, showing that it was able to detect more breast cancers than a mammogram. The only question remains now whether that will change, have an impact on survival, because it's one thing to detect a breast cancer earlier, but have you detected earlier enough so that by removing it, you have prevented it from spreading? And that's the key question. And so we don't know whether that has an impact on ultimately on survival. And those are big tests that have big clinical trials that have been done for many years to find out what the actual impact. As I said, no doubt it looks like MRI, it can detect breast cancers better than mammograms, but we don't know if that is still, if it still leads to any improvement in survival. The disadvantage of MRIs, for instance, is that it also detects a lot of other things that lead to many unnecessary biopsies, and that's a source of anxiety, sometimes complications in the breast, and sometimes surgeries that could become unnecessary. So these are good questions, and they have to be, and they are being tested in clinical trials. I don't think those clinical trials are, at this point in time, are available in Canada, but I may be wrong. But I know
What
there.
about what about the ultrasound part?
The ultrasound is not as sensitive as the mammogram or the MRI. The ultrasound is used more to be able to tell you what you see when you do an MRI and a mammogram. It's specific. It tells you, is it a cyst or not a cyst? Is it looks like a tumor or not? Is it a lymph node, a benign lymph node? And it gives you more details in that sense, but it's not very good as a screening tool. In those women that have very dense breasts, however, the mammogram may not be all that useful either. And then I usually supplement that with an ultrasound to add, in a sense, to the possibility of finding something. But by itself, the ultrasound is the weakest of the three in terms of sensitivity, finding something new. But in terms of deciding what that thing is, it's very good.
Right. And I guess biopsy wasn't asked about, but biopsy is only done once, you see
There's a
the
level of
tumor.
suspicion. Yeah,
Yeah.
when you have a doubt about what it is, then it leads to biopsy.
Yeah, you have to see it first and then go to it. Otherwise, you don't do the biopsy. Okay. Next question is, how easy is it to leave? I guess the person wants to know if they're on a trial and they no longer want to participate, how easy is it to leave? I guess they just leave the trial, correct?
You inform every single informed consent that I think I've seen so far has a clause written in it that the patient has the right to withdraw at any moment. You just have to inform the research person, whether it be the physician or the nurse, the research associate, of your decision, and then you leave. They might still maybe in some cases what they can do is garnish some data about some things, but again, I think they would still need your permission for that. So you can leave whenever you want, but you should inform the person that you're leaving, the person running the trial.
And speaking of that, what are the success rates of individuals staying on for the duration of clinical trials? Is it a good success? Is it a high, low?
I
Could
don't
it
have
be
any numbers
lower?
there, Kathy, but it is good. In generally, it is good, unless well, but that's still you still stay on the trial. Some drugs might have unexpected side effects, and so the person is taking that drug and say, I don't want, I can't handle, or the physician will say, we got to stop that drug. That person goes off the trial, the active trial, but it's still followed as part of the statistics of the trial. Yeah, you can. Yeah, that's a particular situation, I guess, when you have side effects or toxicity, and then the person leaves. But in general, women who are clinical trials, people who are in clinical trials are followed very closely. and they usually complete the trial. It's, you know, if they sign it, they're often motivated also to do it.
And do you find that in general, these clinical trials offer the help and the support to someone who becomes either exhausted by the trial, or no longer wanting to do it, but is confused as to whether or not they will stay on or not? Do you feel that there is enough support for these individuals?
I would hope so. I think, well, the research nurses that I work with would, I think, have the compassion and the empathy to be open and to help, and I've seen that in the past. So yeah, I would say I would say yes in general, but you know, I would hope so.
Okay, next question is, what happens if a trial is stopped or canceled, but the treatment was working for me, like the person
Oh,
asking?
that's a really good question. And actually, there is actually happened that, not to me, to one of my colleagues, where the company, the clinical trial was negative and they shut down, they basically stopped making the drug. But in that one patient, the drug actually had worked. In that one particular case, the company continued making the drug just for that one patient. It's a really incredible story for several years too.
Wow.
So I don't know how that's the only story I've heard like that. It might be very unusual. I don't know, but it was really striking that they would continue to make the drug just for that one person, and that as long as the patient was taking it, he or she was still responding. And I think, as I said, it was for many years. It's
Wow.
yeah,
Yeah.
but that might be a rare story. I haven't heard of such a story again. It's a heartwarming story. You sort of hope that it happens, but I would tend to think, sorry, I'm going to just take some water.
Yes.
I have the feeling that that might be a rather infrequent and rare kind of solution.
Yeah, I would imagine that some of the pharmas who are developing these, trials would want to continue a patient, right? If the patient's doing well.
Yeah. And it was a good ethical choice for the drug company to continue doing that.
I would
But
think so. Yeah.
I don't know if all drug companies have that same standard of ethics. I would hope so, but
Yeah. Anyway, it's still a learning process. Bakun, I'm gonna send it over to you for a couple more from the live questions.
Sure. I actually have a question just related to kind of the access and, if a clinical trial is stopped. So what happens in the case? So, when patients join clinical trials, they don't pay for the drug, but then if it does become standard of care, or if it at least gets approved by Health Canada and, CADA for reimbursement and sale, what happens to the patients who are on that clinical trial between that time of like, okay, it's approved, but it's not yet reimbursed, or it doesn't get approved or it doesn't get reimbursed in their province? Is it like when they stop the clinical trial, then they now have to start paying to access the drug, or are they kind of, grandfathered in? Like, how does the financial?
yeah, that's a good question. I don't know really the answer to that question. I think it depends on a clinical trial, perhaps. Depends on the agreement that in the company. If this person is still benefiting from the drug, in general, the clinical trial would still provide the drug.
Oh.
Because they want to, depending on the follow-up. And usually, you want to follow these patients until progression, or for a number of years, to make sure that the drug is still working. In that case, I think I'm quite sure the drug is provided by the clinical trial. Yeah, so I would think so, but I haven't had it's a good question. I haven't encountered such a situation. I'm not quite sure what would happen in that case, but in the cases that I've seen, as long as the clinical trial was open, active, the patient would continue receiving the drug.
And are clinical trials that are on drugs, are they always run by like pharma companies? Like, who else, like, who runs clinical trials?
No, there are some more and more of the cooperative groups, like the Canadian Clinical Trials Group, CCTG, or the NSABP, NRG, all these other groups ran a lot of the clinical trials, and the drugs would be supplied by the companies, and the trial would be paid for by the NCI, the American NCI, or or a grant. It depends. We do have some clinical trials where we are where the trial is paid for not by the pharma, and others where pharma simply provides the drug.
Wow.
And there's several such trials right now running, even in Canada, where all pharma is doing is providing the drug for free, a relatively experimental drug, whereas the clinical trial itself is being run by a cooperative group like the CCTG. And there's a trial that comes to mind that's doing exactly that right now. So it's a mix, but in general, the big clinical trials, the ones, the blockbuster ones, the ones that change practice, are more and more being funded and being run by the pharmaceutical companies, which of course is problematic by its nature, because they've got a vested interest to make sure that this trial is run well. So there's all kinds of safety measures, shall we say, or guidelines that have been put in place to ensure that the data is being looked at independently, and that the clinical trial decisions are made in as independent as possible decision, usually by what's called an independent data safety monitoring committee or data monitoring committee. That would be independent or at arm's length from the company. But that is an issue, and you have to be careful about that. That was an issue, which is, of course, why these committees were formed, to prevent abuses of any kind. So yeah, and so pharma is funding a lot of the big clinical new drugs. The drugs I mentioned are essentially almost all being funded by pharmaceutical companies. Many of the de-escalation, as you'd expect, the ones we're removing therapy, are not being funded by pharmaceutical companies, and are being funded by grant support, national grants or National Cancer Institute. And so it's obviously more difficult to get funding for those. They're obviously no less important.
Oh, sure.
So yeah, so it's an interesting environment now we're living. I think 20 years ago, the drug companies were more perhaps at arm's length from many of the trials. They're much more involved right now in many of the trials, and that could be a bit of a problem sometimes in terms of even looking at the data. It's perhaps not as easily accessible to somebody outside their committees and outside the people participating. But usually they often these trials are often run through what we call the cooperative groups like CCTG and NACBP, NRG. So that and there's control of the data usually by the groups together with the company, so that the company doesn't have the full control of the data.
Okay. Yeah. So basically, whoever's running it, patients can still feel confident that it's still safe to join those, regardless of who's running it.
Yeah, in general, because there are ethical guidelines, and
Sure.
the people who are running them, the people who are participating must also comply with certain ethical guidelines as well.
And you spoke just about de-escalation now, but also previously within the session. Someone's asking, can you speak a little bit more again about toxicity, clinical trials observing the toxicity of chemotherapy?
Yeah, well, the chemotherapy, there are known toxicities, and so they're always being monitored. And if there's a new drug that's given, for instance, the one I mentioned, the immunotherapy, well, then it might have an effect on the chemotherapy toxicity, and that was all noted, and it was very carefully tabulated. And indeed, there were some extra toxicities, but it came mostly from the immunotherapy itself that was doing it in that particular. But there could be drug interactions, which is why before we go to these big clinical trials, we have to test the safety of combinations, new drugs together with chemotherapy. And those are done in much smaller, what we call phase 1 clinical trials, where we see whether any safety, what we call signals, telling us that this combination may not be safe or may be giving new unexpected kind of side effects. Of course, that's not 1,000 patients. They're much smaller, to be sure nothing is obvious. And then when you start the real clinical trial, you might find something that is unexpected that happens. And then you have to sort of put on hold and sort of take a step back. And sometimes the clinical trial is stopped while the data is reviewed, and then the decision made by the sponsor, which could be the drug company with a cooperative group or whoever, to continue or not to continue the trial.
And I don't know if we've touched on this, but CDK4 inhibitors, any trials on that for early breast cancer?
Yeah, well, there were a bunch of trials that showed effectiveness, and those trials, those results are still being looked at as follow-up goes longer to look for survival advantage. And there are other trials now looking to combine these new drugs with other kinds of drugs as well. And those are trials that are coming up soon.
I'll go back to Kathy for some pre-submitted questions.
Yeah, and before I do that, and I wanted to ask you a couple of questions with regards to the symptoms about in these clinical trials.
Hmm.
How efficient are these trials in understanding comorbidities and the drugs that people are on for other comorbidities as they start these clinical trials, especially if it's, very hard drugs that they will be taking during this time, and how well is it, differentiated? Like, it's the drug, or is it the combination of, or is it just your,
Yeah. So again, in the eligibility criteria, the research person or nurse is supposed to find out what are all the comorbidities, the drugs that the patient is already taking, and to discern whether together with the physician whether there are any potential interactions with the new therapy. Often when there are known or presumed interactions, and those patients taking certain drugs are not eligible for the clinical trial because it is thought, well, the risk could be too high. But in some cases, it's not clear, and then those things come out, and perhaps new discoveries are made, whatever, and then those are sometimes amendments are made to clinical trials, saying, well, if you're taking this drug, then you should beware. A classic example is tamoxifen and antidepressants, right? Taking antidepressants modifies the metabolism of tamoxifen, and that's something that was not known when tamoxifen trials were being done, but now it is. So now if you're taking antidepressant, then you may not be eligible for trials in which tamoxifen or similar kinds of drugs are being tested.
But what about women that are not on a trial? Are they still continuing with their tamoxifen if they have?
Yeah, well, that depends on again the situation, but now that interaction is known, and so if you have given a choice, you might want to switch to another drug that is not tamoxifen, or you'd want to just it's the data is actually not very complete yet there to find out exactly what to do and which drugs and what kind of dosages of these antidepressants, which ones in particular. There's still more data needs to be garnered, I think, there.
And clinical trials in itself, like from pharmaceutical companies, do you find that there's a lot of thoughts and ideas from, general population about going on to a trial because they're afraid of because it's industry that's putting out these drugs, and their reluctance. Do you think that this is something that is a factor in the low percentage of women that in this case want to participate in these trials?
I don't think that's the main factor. I think that could be a factor in some cases, but I haven't seen that often raised. I think the most important factor of the low participation in clinical trials is simply not knowing about the trial. Strangely enough, and that's how we came back to the first part when we were talking about access or knowledge. Many physicians don't know about the clinical trials that are going to forget about the clinical trials as we're busy taking care of what we're taking care. And that's why patients are often not enrolled or not approached for these clinical trials. You need a whole operation in a sense, which is where a cancer center comes in, where you always raising the awareness of physicians about a new clinical trial that is here, or this old clinical trial needs more that is available. And we unfortunately tend to forget, or tend, in the brouhaha of regular clinical work, sometimes forget about clinical trials, and the patients are often not aware of them, which is why it's good to talk about them today. And that's the main reason why we have, I think, relatively low participation in clinical trials. It could be much higher, and the physicians as well. The physicians have got to be more aware of them, and also do a better job of explaining them, I think, to the patients. so as not to raise, not to make them afraid of something which is unusual. The patient will sometimes come to me, does that mean I'm a guinea pig? And you know that, well, I've sort of lost the argument already there.
Yeah, yeah. It's interesting. Yeah, we try very hard to reach out to ensure that individuals understand that there are clinical trials and what they can do to participate and to learn about clinical trials. Because sometimes even clinical trials itself, they don't understand what it's all about, the commitment that goes along with it, obviously, and the endurance from a patient and how much that would take up part of their life for a certain amount of time. I'm going to go on to the
sorry,
Oh,
Kathy,
go ahead.
I'll just say this thing, but it's true. What you're saying is absolutely, I completely agree with it. Yet, that is the way to for some of these patients to get potentially better therapies than what the standard therapy would get. And that's a strong motivation, I think, for us physicians to talk about clinical trials, because you have potentially you have a way to improve the care for your own patient. And so it's really, again, I bring it back to the physician's forgetfulness or whatever, but we really should care about these clinical trials, because it often is better therapy that is being provided for your patient.
Right.
I'm wondering if the patients also have like a mindset, I guess, depending on what type of breast cancer they have, if they're kind of like, well, the standard of care is good enough, so there's no, because you're speaking about, we can better the standard of care, but if it's maybe a stage 1, low risk breast cancer, it might be like, well, why would I, go on a clinical trial if the standard of care is so good and, everything is already, I can just.
Well, in such a case, I would say, well, there are clinical trials of de-escalating therapy. Your prognosis is so good, you might be able to avoid toxicity or the side effects of certain drugs, and no drug has no side effects. So that's the way. One of the ways when patients come to see me, very quickly in my conversation, I say that, well, we do a lot of research here. And we do a lot of research in breast cancer, and that's how we've gotten to where we are in terms of the fantastic survival that we have with breast cancer, right? And voila, and in a positive way, you can participate, but perhaps in that.
Yeah, and that's what we strive to do at CBCN, to ensure that people are aware and that we try to increase the participation in clinical trials, because we do understand how important it is to advance, patient care and survival overall.
And for that particular patient, you might get better therapy.
Yeah, exactly. So this question is an old question that I've always heard of, is around the information of the results of breast cancer trials. Often, people go on these trials and then they don't get any information and they don't have any results, and it's possible because of all the years that have gone by, and by the time everything gets, is there a way that patients can find this information if somebody has not given it to them, or how does this work?
I mean, yeah, that's good, because and sometimes I can't get the information. I mean, of the ones I participate in, for sure I can. But if I'm looking for some clinical trials, and I want to know, in fact, I was looking for I'm testing a new drug in the lab, and I want to know if it's been tested. I'm trying to look for instance, there's a clinical trial. Where's the data? Where's it in? I wasn't able to find a report or a paper yet published. In fact, there's a website which actually tells them they're delayed. They've been late in producing the results of the clinical trial. There's actually an NCI website that I found today which actually tells you these things. So they're ethically, they should produce these results, but sometimes they take years. Especially, I assume that they're not very interesting results or very positive results. But you should ask your physician. You really should, and that your physician should know, or should find out what the results, but should know what the results are. I sometimes get that question. And so what did it show? What did it show? And then it showed this or that. And obviously when a clinical trial was positive, I'm very very happy to tell the patient, well, you participated in a clinical trial that, you took this drug and it's, it's what everybody's doing now, and it's really changed things. And it's really positive reinforcement. So I try to, but you should really ask your physician, your oncologist to tell you what happened.
Yeah. I wonder if
Not
often,
scared, but
yeah, I wonder if often patients just finish off and that's it. It's part of their past. And, sometimes they don't even go back to search unless
You're right.
necessary,
Yeah.
unless necessary to find out what happened if, God forbid, something else comes along further. Okay, so there's a question here about trials on managing the side effects of breast cancer treatments.
Yeah, there are such trials. Yeah, there are different kinds of trials that are looking at that, different kinds of interventions, not necessarily drugs, or homeopathic things, or acupuncture, things like that. There are different kinds of trials there as well. Yeah.
Okay.
And I don't know, you have to find out whether they're available at your center, whether they're accessible, but there are such trials. Yeah.
Okay. And if a treatment seemed to be helping, can patients still have access to the treatment when the trial ends? I guess we went over this just previously, but in general, I guess it depends. It depends on whose drug it is.
If you're in the member in the trial, I think that if you're in the trial itself and you're on the arm that got the new treatment and it worked, I mean, those treatments are not forever, right? Usually most treatments are not given more than 5 to 10 years. I suspect that on that clinical trial, you can continue doing that, I would think, until the end of till the whatever time you don't need to take the drug anymore. I would think so, but I could be wrong there, but that's my impression.
And when a patient signs this consent, which is often a Bible, what part of all these questions is included? Should they not all be included so that the individual is aware, even if they're not thinking about it, but these are perfectly legit questions that, in that big Bible, somewhere this should be stated.
Yeah, you're right. The Bible usually concentrates on long lists of potential side effects, which are horrifying, and perhaps less so on these kinds of questions. Yeah, it's a good point you're making, Kathy.
Yeah. Bakun.
Of course. So we have a question that's non-drug related. Any clinical trials for lymphedema due to cancer treatment?
Good question. I'm not aware of any that are open right now, but I know there were some in the States. Yes. There were some. There are different. There's a surgical procedure that was being tested to re-anastomose the lymphatic channels. There were some different kinds of I think there were a few trials, not that many interventional as far as I know, but a few there were. And I don't know what stage they're at right now. We didn't have them open here, or I don't know whether the rest of Canada, I suspect not that much.
I have a question around the lymphedema, Bakun. Sorry, I'd like to interject.
Go ahead.
What are the lymphedema? So is it less so now with surgeries being modified from the earlier ways of doing lumpectomies, etc.? Is there less problems around lymphedema because of that?
Yeah, because we're not doing axillary dissections anymore,
right?
Or we're not doing them often. Sometimes we are, and we're doing sentinel lymph nodes, which is just removing 1 or 2 lymph nodes that are close to the breast cancer, to the breast. And there's a study just came out a week or 2 ago showing that we might not even doing that many sentinel lymph nodes anymore. So we're doing less and less in the axilla, and therefore there's less and less chance of lymphedema. And we're seeing, of course, less and less of it. Yeah.
So then if you don't do the lymph nodes, how do you detect any
we do an ultrasound before, and we use the ultrasound to tell us if there's anything obvious in the axilla, and there isn't. There are studies now have shown that it doesn't matter, that if you don't go in there, it won't change anything in terms of the survival of the patient.
And did this all come about because of a clinical trial?
Yeah.
Okay.
Absolutely. Yeah, where they did, half the patients got a sentinel lymph node, the other half didn't. If the axillary node ultrasound was negative, then half the patients got surgery, half the patients didn't, and there was no difference.
Okay, good. Bakun, sorry, I interrupted.
Oh, no worries. So someone read about a trial that's actually starting at the Jewish hospital for cancer patients for first line of therapy, or if first line of therapy chemotherapy has failed, with the idea to inject the chemo to the place where the cancer is located. They're wondering, well, have you heard about this, and is it open?
That's in breast cancer?
Yes. Well, they said cancer patients. So maybe it's
Yeah, so there is a trial. I don't know if it's open yet, and I think it will eventually be in breast cancer, but not yet, in which there's an injection of a new kind of intervention around the site of the tumor, in metastases of the skin, for instance. That is coming up. So that I can say yes. I'm not sure if that's the trial that they're referring to. There have been injections into tumor of different drugs, but and that is still being studied in general. That's what I can tell you. I don't know of a trial like that here, the Jewish in particular, except the one I'm talking about, which is actually a very interesting idea of injecting these cancer, shall we say, cancer-eating bacteria around the tumor, so it eats the tumor. That's coming up.
Okay.
So we had another, going back to the CT DNAs that you were speaking about. So can someone still use CT DNA like Signatera if their surgery was a few years ago?
Yeah, you can. Signatera now markets the test. It's quite expensive. It's several $1,000s to patients, and they actually market it now in Canada as well. The problem is that I would not do it until we have a clinical trial that shows that it actually is useful to do it.
Right.
Because the worst thing that you do is you get this test back, it's positive. Okay, and then you get, let's say you do a PET scan and find nothing. Okay, what do I do with this result? Does that mean I'm going to get a breast cancer in a year's time, but there's nothing I can do about it and I can't see it? It's not exactly a happy situation to be in. And so we really have to show that these tests, they're really, really sensitive, they really work well, but we have to show that it actually makes a difference knowing these things. Sometimes knowing this is not necessarily useful if you can't do anything about it. And that is something that is still not been shown that much in circulating tumor DNA, certainly not in breast cancer. In colon cancer, there's a study that did show potentially that it might save some chemotherapy, but that study is a bit weak and it's being repeated right now. So there's a lot. That's why I said at the beginning, there's a lot of clinical trials now coming around for circulating tumor DNA for liquid biopsies to find out how much it's actually going to change things. It's not enough just to know something. It has to be able to actually change what's going to happen.
For sure. And then the second part of your question was just how do they get a sample of their tumor at baseline?
What do you mean?
I guess, well, related to maybe when they're asking about doing these tests, like, is there a way to get a sample, like their tumor?
Pathology, all the samples, all biopsies are kept in pathology archives departments for many years. So, you can go back and get things tested sometimes years later. Yeah.
So they heard about this is a CHARM study, so cell-free DNA through blood tests. Will this eventually become a trial, or is it already a clinical trial?
That's a study. Actually, yes, it's becoming a clinical trial. Actually, that's an interesting question. Somebody must know something. Because the CHARM study we're actually participating in that. We're actually using circulating tumor DNA in women that are at high risk, that have genetic mutations, that have mutations in BRCA1, BRCA2, for instance, and also in other kinds of cancers. We're trying to see whether the circulating tumor DNA can detect the cancer before it's detectable in these women that are at very high risk of getting breast cancer. And so these studies, the study was ongoing, and now they've received funding to actually open a clinical trial to do these tests and if it test is positive, well, then you get a whole body scan looking for things, and then depending on what happens there, you get therapy or not therapy. So there's a clinical trial that will be started, I hope, within the next year. I'm on the actual committee of that trial, and we're sort of planning things and trying to figure out the fine tuning, the mechanics of it.
Perfect. And then I'll ask this as my last question since we're coming to the end. So someone's asking, is Keytruda being used for resistance for TNBC?
Yeah, it's being used in recurrence. I guess that's resistance, right? In a metastatic setting, it is. The Keytruda or pembrolizumab, or this immune therapy that I talked about earlier, is it decreases the chance of it improves the response to chemotherapy. So in that sense, one could say it decreases resistance to chemotherapy. But if you do have a resistance, if you have recurrence, yes, then that drug is actually useful in triple negative breast cancer, especially.
I'll sneak one last question in because it's about the CHARMS trial. Do you think people who participated in the CHARMS study will be invited to participate in the trial?
I don't know yet, to tell the truth. It might be a different set of patients, but I really don't know. That's a very good question. I just don't know. It's still too early. We haven't figured that out yet.
No problem. Kathy, back to you.
So like she said, we're coming to the end, this is it, but I'd like to, offer you a couple of minutes if you have anything that you would like to add, or how we can increase the knowledge of clinical trials, and how we could better do outreach and, collaborate from our organization with the physicians, etc.
I mean, holding meetings like this, and just spreading the word that clinical trials are in general are a good thing. They do improve the outcome of patients who are on the clinical trials, and they help advance the quality of and the help improve outcomes for cancer patients in general. They're necessary. We need to do more of them. We need more funding for them. From testing new drugs to removing drugs that are not useful with new tests. I think there's a lot to be done, and it's a very exciting time, because we're going in both directions. We have new drugs that were really cool, and at the same time we have new cool tests that allow us to treat better and treat less.
Right. Yeah, it is.
So ask your physician is my I guess, and encourage every single patient to ask the physician about clinical trials.
Yeah. And one last question, anything that will be blockbuster will certainly be
Vaccines for breast
available
cancer.
as it becomes, right? Like, I mean, these things, people have a fear that, it's kept a secret, but if there's something that is out there,
nobody wants to keep a secret. First of all, we want to see our patients do better.
Right.
Drug companies want to make money.
Right.
Researchers want to
call it what it is.
Researchers want to have their new discoveries applied to save patients as well. So everybody wants it to work. The only question is to do it in a very controlled, safe kind of way, and that's where clinical trials are being done, to make it sure that it actually is helpful and it doesn't have bad side effects, harmful side effects that might outweigh its benefits. And that's why you need to really, in a very rigorous, scientifically rigorous way, do these clinical trials. You gather all the data properly.
Right. And I think my takeaway from what you presented to us today is probably key in just relaying to the patient that you will be taken care of even better if you choose to participate in a clinical trial. So I think that should be, first and foremost, before, you engage somebody to start thinking about participating in a clinical trial, because often they think it's all for them and what's in it for me. But just the idea of being better taken care of, I think that alone is a great feature for somebody to seriously consider participating.
Yeah, you're
And with,
absolutely right.
yeah, and
Studies
with
have shown clearly that patients who enroll in clinical trials do better.
yes, exactly. And I think we have to put that out a lot more
Yeah.
than we have been in the past. So with that, thank you, Dr. Basik.
Thank you,
Okay,
Kathy. Thank you.
great engaging
Beaucoup.
discussion. And this, of course, brings the the end to our session. And thank you everyone for your excellent questions beforehand and during this session and for joining us. And thank you to our participants for attending and all the great questions that you asked this afternoon. After the session, you will be sent a survey to provide feedback on this particular session. Please fill out the survey as your responses help us to make this session, these sessions better. And once again, thank you to our sponsors, Viatris, Novartis, Amgen, Gilead, Merck, and Seagen. And with that, everyone have a good afternoon.
Thanks,
Bye-bye.
Ev.